Good morning, everyone. Myself Namrata, cardiac sonographer from Jaideva Hospital. Today I am going to discuss a case on concealed rupture of aortic aneurysm with large thrombus. At first, I'll brief about what is aneurysm and aortic dissection or rupture. Aneurysm is a where dilatation of aortic diameter at least 1.5 times greater than the expected normal diameter. For example, like greater than or equal to 4.5 centimeter to 5.4 centimeter. Aortic dissection or rupture is a serious condition in which there is a tear occurs in the inner layer, that is aortic intima, through which allows blood to enter the aortic media, which this is the picture example of thoracic aortic aneurysm and abdominal aneurysm. This is fusiform aneurysm and saccular aneurysm, the differentiation. Okay, here there is a 58-year-old male patient presented to emergency with a complaint of dull, non-radiating chest pain since 3 to 4 days, breathlessness, severe back pain, and associated with SOB, nausea, but no vomiting. He had a history of hypertension since 5 years, regular on medications. From past 1 month, he had on and off lower back pain, and he was smoker since childhood. On arrival, vitals were like normal. BP, right-sided BP was 130/80, left-sided BP was 120/80. Pulse were 82 per minute, but lower limb pulses were weakened. At initial, we treated him with IV fluids, continuous BP and cardiac monitoring. Blood investigations were done and advised for further diagnostic procedures. The general diagnostic procedures which are going to be done are ECG, X-ray, echo, CT scan and MRI. For this patient, MRI was not done. This is the ECG at the time of arrival, which showed sinus tachycardia with the borderline LVH pattern. This is another ECG after 2 days of admission, still the same. Chest X-ray of the patient, which suggestive of cardiomegaly. The haziness is because of severe right-sided pleural effusion. And then echo. Echo showed concentric LVH and aneurysmally dilated abdominal aorta and thoracic aorta. Here, this is a plaques view where we can see LVH. This is the color flow. We can notice there is no any significant aortic valve or mitral valve regurgitations. This is proximal ascending aorta, which is normal, measuring around 3.5 centimeter. Here we can notice there is a thin borderline thrombus formation. Short axis, here also we can appreciate LVH with the good LV function. Aneurysmally dilatation of the abdomen from here to here, if we measure, we'll get around 6.2 centimeter filled with large thrombus. This thrombus is formed because of intramural rupture. Here we can see false lumen. This is descending thoracic aorta. From here to here, we can see aneurysmal dilatation, which is measuring around 5.1 centimeter. Here also we can see the formation of thrombus. Arch and descending aorta, which were normal in this patient, but echo window was not that much appreciative. Here there is CT scan. In CT scan, it is suggestive of dilatation of distal descending thoracic aorta contained rupture, concealed rupture. Meanwhile, there are few proximal and coelenteric artery occlusions. Here we can notice aneurysmal dilatation of the abdominal aorta and descending thoracic aorta. After all this diagnostic procedures, patient was under observation for 1 week and stabilized. Later on shifted for surgical procedures where surgeons were advised for aneurysm repair. In general, for these type of cases, end-to-end vascular repair or grafting can be done, where they'll put conduit. Here, take-home message was: quit smoking, stop unhealthy foods and eat healthy meals, regular exercises and be physically active. Older people, regular cardiac checkups, avoid alcohol and stay sober. Thank you.
Good morning all. Myself, Devi, from working as assistant professor from Department of Cardiovascular Technology, MCHP, Mahe Manipal. Here I am going to present a case titled Giant Metastatic Sarcoma in the Left Heart. Introduction. Metastatic cardiac tumors typically originate from the lung. Other common sources of cardiac metastasis include breast and kidney carcinoma and lymphoma. Metastatic tumors of the heart are more common than the primary cardiac tumors. The most common primary tumor resulting in cardiac metastasis is carcinoma of the lung, with there being only a few reports of metastasis from esophageal cancer. Here, patient history in 2018, a 55-year-old female had swelling over left proximal tibia, for which she underwent wide local excision in another hospital. Biopsy done there showed osteosarcoma of tibia. After 1 month, she presented to our hospital with complaints of acute onset of pain and swelling over left knee joint, insidious in onset and gradually progressive. She had no history of fever, weight loss, or hypertension, diabetic, ischemic heart disease, and bronchial asthma. MRI showed features of undifferentiated high-grade pleomorphic sarcoma with unknown margin status. In view of high metastasis suspicious of tumor, she underwent an ultrasound of abdomen, pelvis, neck, and sonography of breast. Benign hyperechoic nodule in right thyroid lobus revealed. She had no cardiac symptoms. ECG, X-ray, and echocardiography done was normal, and cardiac CT was requested for suspected malignancy, but no evidence for the same was noticed. She was hence planned for adjuvant therapy. The patient completed her radiotherapy treatment on April 2018, and she frequently visited our hospital for follow-ups. Once again, patient again presented to oncology OPD with complaints of right knee pain in 2022. On examination, thigh nodules were noticed. Patient was referred for PET CT in suspicion of malignancy. This PET CT study showed hypermetabolic enhancing multiple skeletal lesions involving right lower limb, hypermetabolic soft tissue density nodules predominantly involving the right lung, left pulmonary vein tumor thrombus extending into the left atrium. She was admitted again for CT-guided lung biopsy. Section from lung showed malignant spindle cells arranged in focally elongated hyperchromatic nuclei and few skeletal muscle fragments. The patient was planned for chemotherapy. Prior to intimation of chemotherapy, baseline cardiac investigations was sorted. On physical examination, heart rate was 72 beats per minute and BP was 110/80 mmHg. These are the laboratory parameters. And ECG showed sinus rhythm. There was no STT changes. This is the X-ray. X-ray showed pulmonary venous marking appeared prominent. Coming to the echocardiography, this is the parasternal long axis view and parasternal short axis view. We can see some structure left ventricle through the mitral valve. Here we can see clearly in apical four-chamber view. It is from the right superior pulmonary vein to the left atrium protruding through the mitral valve to the left ventricle, measuring around 7.5 into 2 centimeter. This is the same view, apical four-chamber view with color flow. We can see the mild gradient across the mitral valve. 7.3 centimeter mass seen filling left atrium, extending into mitral valve to left ventricle. Mass seems to be extending from pulmonary veins. So issue of tumor mass or thrombus. Mild mitral inflow gradient noted. Normal biventricular systolic function. No regional wall motion abnormality. No significant MR or AR. There was mild TR bar pulmonary hypertension. This is the cardiac CT. Revealed mass in the left atrium through the mitral valve to the left ventricle. And patient was referred for CT-based consultation, but the patient did not undergo it. Chemo was given. On telephonic conversation, patient was advised to visit the cardiology OPD and get an echocardiographic test for evaluation of cardiac sarcoma post chemotherapy. These are the medication advised during discharge. Patient was once again admitted with moderate to severe pain in the right chest and back, radiating along the right flank in 2023. However, patient's family reported significant financial constraints regarding hospital and medication expenses. Consequently, the patient was administered an equivalent dose of for the pain management. Following symptomatic improvement, the patient was discharged in a hemodynamically stable condition. However, during a follow-up telephonic conversation, it was reported that patient has passed away within 1 month of discharge. Learning points: undifferentiated pleomorphic sarcoma in an uncommon soft tissue cancer with a high transmissibility property. This case report presents a rare case of large malignant cardiac tumor diagnosed incidentally. Differential diagnoses are LA myxoma, lipoma, metastatic sarcoma. These are my references. Thank you.
Good morning, ladies and gentlemen. My name is Veena Shavi. I'm working as echo technician in Department of Cardiology, Manipal Hospital, Yeshwanthpura. Today's case is a case of appearing and disappearing mass. A 29-year-old lady presented with fever cough for 4 days and was treated symptomatically with antibiotics on an OPD basis. She presented after 2 weeks with fever, body ache and chills. So she was admitted through the ER to the internal medicine and further investigated. She was tested negative for dengue, COVID, H1N1. Her total count was 8,300 cells per mmQ. NT-proBNP was 21,000 picogram per ml. She was treated with antibiotics and flavor. This is the X-ray. You can see cardiomegaly, increased pulmonary vascular markings. She was referred to high-resolution CT showing cardiomegaly, pulmonary edema, and lung consolidation. We did an echo in the ER. This is a parasternal long axis view showing dilated LALV and reduced LV systolic function, and the apical four-chamber view showing dilated LALV with global hyperkinesia of LV. This is a short axis view showing reduced LV systolic function, and a four-chamber view showing moderate mitral regurgitation. She was managed with diuretics, MRA, and a small dose of RD, stabilized and discharged after a week. So after 10 days, she presented again with lower abdominal pain, increased frequency of urination, and fever to the ER. She was diagnosed to have UTI infection. Therefore, oral antibiotics was started, and the screening effort persistently showed EF of 25%. So ultrasound of abdomen and pelvis showed features of pyelonephritis. Urine culture was positive for E. coli. Therefore, she was started with IV ertapenem and started with nitroglycerol for 2 weeks. A month later, she presented with upper respiratory tract infection. So therefore, we started her with levofloxacin with screening echo persisting 25%. A week later, she was admitted to the ER with loose stools, vomiting, tiredness, hypokalemia, and resolving UTI. She was having hypotension. Therefore, we had to discontinue the RNA. The urine protein was positive for albumin and 5 to 6%. CVP was inserted, piperacillin and tazobactam was given. Now the urine culture had no growth. She was discharged after a week. The pre-discharge BP was 80/40 mmHg, hence the RNA was withheld. She came follow-up for after 1 week to the OPD and she was doing good. 2 weeks later, she had a fever for a day. So the CT knap showed splenic infarct, mild bladder wall thickening, and the EF had improved up to 35%, but found to have a clot in RA and RV. So therefore started with low molecular weight heparin and acetron to switch to acetron after 2 weeks. Because of the disc corruption, we don't have the images of this. We further investigated and found that ANA panel was positive for lupus, RO53 and SSB3 positive. C3-C4 was normal competence level, alpha was negative, and urine ACR was 70 mg per gram. Urine protein was present. It was categorized as class 1 lupus nephritis, started on immunosuppressants. A month later, the clots in the RV was resolving and the EF had improved up to 40%. A month follow-up, there were no clots in RARV with the improved EF of 40%. The thing is, now she stopped the anticoagulations by her own. So a month later, echo showed LV apical clot measuring 2.5 to 1.5 with an EF of 50%. So we commenced again with acetron. This is a parasternal long axis view showing improved EF compared to the baseline. Here we have 2.5 to 1.5 mobile LV apical thrombus with a quite improved EF compared to the baseline. It's not 25% now. And a short axis view showing LV apical clot. C3, C4 was normal. TB quantiferin was negative. Received 2 doses of rituximab, and 1 month later, EF was 50 with no clot. 2 months later, normal LV function, EF of 55%, mild MR with no clots, and this is the last echo follow-up. Parasternal long axis view and 4-chamber view showing borderline LV, adequate LV systolic function and no clot. To summarize, it's a case of rare case of lupus myocarditis with LV dysfunction causing thrombus in RARV and LV. Cardiac manifestations completely resolved with steroids and anticoagulations. Diagnosing SLE was the key in the management of this patient. Thank you.
To IAE to giving this opportunity. Myself, Shilpa Beluraswamy. I'm a cardiac sonographer and a lecturer working in Saptagiri Institute of Medical Science, Bangalore. My topic is usual thing at unusual site. A 7-year-old male presented to OPD with the complaints of palpitation, and he had a past history of PDA ligation when he was 2 years old. On clinical examination, the pulse is around 90 beats per minute, and BP is around 110 bar 80 mm of Hg, and SpO2 is around 97% on room air. On cardiovascular examination, S1, S2 heard and no added sounds and murmur. The 12-lead ECG shows normal standardization, normal sinus rhythm. There is no chamber hypertrophy or enlargement, but there is a juvenile T-wave inversions were present. X-ray of AF view shows no cardiomegaly and lungs fields are clear. As is a pediatric patient, we started with the segmental approach. Here the IVC is on the right and the abdominal aorta on the left shows the situs solitus. We checked the position of the heart is levocardia, and we kept color secret across the interatrial septum and the interventricular septum to rule out any obvious shunting lesions. And we gone to the thoracic imaging and we focused at the aortic level. We have found out NCC is mildly prolapsing, causing trivial to mild aortic regurgitation. We gone to the classical parasternal long axis view. It shows the 2D modality shows the chambers are non-dilated and hypertrophied, but the coronary sinus is dilated. Here we can make out the thin linear filamentous structure is moving inside the left atrium. We kept color secret across the mitral valve. We can make out anterior mitral leaflet is elongated and the A2 scallop is mildly buckling and causing trivial to mild mitral regurgitation. We gone to the short axis view at the aortic level. It shows again the NCC prolapsing. As we already seen the plaques view, the structure which is moving in the left atrium, we can even make out that structure is attached to the interatrial septum as well. As we undergone to the PDA ligation, we kept color sector across the pulmonary branches. There is no residual shunting across the PN branches. We gone to the basal and the mid-level of the left ventricle. There we can make out the commissures are free of calcification and fusioning, but we can make out the linear thin structure is moving exactly at the scallop of A2 and the P2. And we can make out in the short axis view at the papillary muscle level, the thin strand is hitting to the lateral papillary muscle of the LV. At the classical 4-chamber view, while giving an anterior tilt, we can exactly make out the attachment of the thin linear structure. Here we can see even at the zoomed level of the mitral valve, the thin linear structure which is hyperechoic attached to the superior aspect of the interatrial septum, crossing the co-opting zone of the mitral valve and attached to the lateral papillary muscle and causing the trivial to mild mitral regurgitation, and there is no significant gradient across the mitral valve. 3-chamber view of the heart shows the exact movement and positioning of that linear structure, which is freely dancing inside the heart with beat to beat. And aortic valve shows a mild aortic regurgitation, and focused view of the RV shows mild tricuspid regurgitation and the mild pulmonary artery pressure. Suprasternal view shows no coarctation of aorta. As coronary sinus is dilated, we got bilateral SVC. So what will be the diagnosis? We have concluded this case as isolated non-obstructive accessory mitral valve cardiac tissue which belongs to the type 2, elongated AML causing mild mitral regurgitation and good biventricular function. Then what is this AMVT? Accessory mitral valve tissue is a rare congenital cardiac malformation which occurred because of the abnormal or the incomplete separation of the mitral valve from the endocardial cushion during the cardiac development. Rarely it is associated with the VST, PDA and the TGA. Most of the time it will be the incidental finding, depends on the attachment, it will lead to development of the left ventricular outflow tract obstruction. This AMVT has classified into a 2 category, one depends on the morphological, another one depends on the attachment. The morphological classification consisting of type 1 which is fixed type and type 2 will be the mobile type. Type 1 is again classified into A and B. A is nodular and the B will be the membranous type. Type 2 will be divided into again A and B which is pedunculated and the leaflet type. Depending on the attachment, it is considered consisting of type 1 above the valve, type 2 will be on valve, and type 3 will be below the valve. Most of the time, around 70%, in these rare cases, it is attached to the LVOT, causing LVOT obstruction. So what are all the complications this AMVT leads to? It leads to development of mitral regurgitation, LVOT obstruction, and rarely leads to arrhythmia. So what are all the management criteria? So management consisting of asymptomatic patient need a regular follow-up to rule out whether the worsening of the condition, and the symptomatic patient, whether if it is a significant obstruction or regurgitation is there, need an AMVT excision and the valve repair. So these are the reference articles which have gone through to conclude this case. And take-home messages will be all congenital patients should screen carefully without missing such additional findings. 3D imaging should be done wherever it is available. Need on-time follow-up to rule out worsening of the condition if not fitting into the approval criteria. Thank you, one and all.
Let's start. So, I'm Varsha Valavalkar again from Narayana Institute of Cardiac Sciences. I work in Pediatric Cardiology Department. So, I saw this case, a rare case of aortomitral curtain anomaly. So, we had a 4-year-old female presenting to us with a history of right-sided, there was a weakness of right-sided limbs. There was speech difficulty in eating food for past 5 months. There was history of fever, seizures, and she was diagnosed to have stroke. And also repeat stroke, which followed with, loss of consciousness for 12 days and ventilatory support for 30 days. She was detected to have CHD elsewhere. She presented to our outpatient, and on clinical examination, she had excessive precordial activity. There was no cyanosis, no clubbing. At Trumer, the saturation was like 99%. On auscultatory finding, there was to and fro murmur and grade 2/6 murmur at left third intercostal space. On neurologically, she had right hypertonia and facial weakness. So ECG did not have much. It was sinus tachycardia. On X-ray, there was mild cardiomegaly with normal pulmonary vascularity. So let's go to echocardiography. On 4th chamber, we saw only LLV dilatation. There was no valve regurgitation or anything. Only thing is what we saw on 4th chamber was LLV dilatation. We went to long axis. We just saw little bit of, the kind of left coronary sinus of Valsalva was slightly kind of bulging. But we were not sure what was happening, and there was severe AR what was seen. We went to next view. With a little anterior tilt, we started seeing that bulge was increasing, that sac was increasing, and that sac was kind of communicating with the aortomitral curtain, the fibrous continuity what we see normally between the aorta and mitral valve. So that kind of that aneurysm or whatever that pouch was joining into the aortomitral fibrous curtain. Okay, I think it is quite clear here that there is a continuation of that some aneurysmal sac is protruding. Okay, you can see that. In parasternal short axis, again we saw there was a dilatation of left sinus of Valsalva. We were not sure, again AR was seen, we were not sure whether there is a rupture, because you all know that hallmark of a rupture is you see a kind of, what do you say, you actually see the opening, so-called windsock opening, what you see usually in a rupture of sinus of Valsalva, that was actually not seen. So we were not sure whether there is any rupture, but of course there was dilatation was very clear. Then again, holodiastolic flow reversal in the arch, which also goes with severe AR, okay. Again, in abdominal aorta, so more specific that, when you start seeing flow reversal in abdominal aorta means, yes, it is severe AR, okay. This is a very interesting picture, which we got it from subcostal. And till we went to subcostal, we could not, see this image, You can actually see Okay, you can see here that this is LV. Sorry, this is an inverted image. This is what we do in a congenital heart disease. This is usually used in pediatric cardiology. This is how you see people who are practicing adult echo may be seeing ventricles up. So maybe you're getting a little confused, but this is how we see anatomical picture of the heart. Okay, so you can see that, this is the LV giving rise to aorta and and then this one, if you can see this one, that is a aneurysm actually. This is an aneurysm which is arising from the left coronary cusp, that is from the LVOT left coronary cusp, and extending into the iotomitral fibrous curtain. So that is become wide mouth. Got it now? So much more clear image. If you can see this is a little clear image, and you can actually see the aneurysm joining the continuing into the intervalvar fibrosa. Okay. Please remember this image. Whenever, this is very rare, whenever you see such case, you should not be missing this case or misdiagnosing this case. Okay. So what we diagnosed on echocardiography was, actually I saw this case in the OPD and my diagnosis was what I have written here. I just diagnosed it as, because I had read it somewhere, but I was not very sure. So I just gave it as, iotomitral aneurysm. I actually added fibrosa, but I had given iotomitral connection with a aneurysm, okay? Extending into the iotomitral curtain, okay? There was suspected left sinus of Valsalva rupture and severe AR on echocardiography. CT scan showed, I wouldn't go to this because that is just 4-chamber. You can actually see here the arrow shows the aneurysm extending into the iotomitral curtain, okay? So CT scan, additional imaging always is important because this can actually help you in confirming your diagnosis, especially such cases, and CT scan also confirmed the diagnosis. What did we do for this case? Surgical management. There is nothing else you can do. You have to do surgery for such cases. So surgical management was, they did an aneurysm repair and they did a valve repair, okay? And there I asked the surgeon what were the per-op findings, and per-op findings was he found a wide mouth aneurysm from in the iotomitral fibrous curtain, and there was a small defect in the LCC which he repaired. This is the post-operative, fantastic surgery done actually in our institute, and this is the post-operative. You can see how much is the AR. There is no aneurysm, there is no flow into the aneurysmal pouch, nicely repaired aneurysm. There is no flow reversal in the arch. You can see the difference. It's really good repair. So little bit of discussion. Do I have time to discuss little bit? Okay. I'm sorry. So I think this is the case. I think all of you should remember not to miss. That's it I can say. And the conclusion, just 2 minutes, I think the conclusion would be one should also assess whether it is congenital or acquired. Don't miss whether it is congenital or acquired, and because the management of both will be different, congenital and acquired. So make sure to see the etiology, what is the etiology, okay? And timely diagnosis of this case and early intervention is very important to save the life. Thank you.
Vascular Technology, MCHP Manipal. Today I will be presenting a rare and interesting case of vegetation involving many valves. So, infective endocarditis is a known complication of congenital heart disease with the multivalvular involvement occurring in 12 to 30% of cases. While streptococcal endocarditis is well documented, granula catala idiocin, it is a rare but serious pathogen which is associated with higher rates of treatment failure, relapse and mortality. So coming to patient history, 42-year female presented to the OPD with the chief complaints of abdominal pain, dull aching pain and generalized fatigue, present for the past 3 months. She had intermittent fever spikes of low grade and bilateral lower limb pedal edema with non-pruritic purpura rash present for past 7 10 days, and she had occasional palpitation and exertional shortness of breath. Past history, she is a known case of cyanotic congenital heart disease with the perimembranous VSD. On physical examination, her pulse rate was 122 beats per minute and BP 130/70 mmHg, respiratory rate 18 breaths per minute. She was paler and edema and splenomegaly was present. Cardiovascular system showed increased JVP, pansystolic murmur, hyperdynamic apical impulse, and thrill present in the lower left sternal border. Laboratory findings, her blood culture revealed granulocatena adiacin, and her hemoglobin, iron level, total iron binding capacity was low, ferritin level was high, and her WBC count, CRP count was high, and creatinine level was high. Her ECG showed sinus tachycardia with no STT changes, and X-ray showed mild cardiomegaly. Echocardiography. So this is the parasternal long axis view. Here we can see a dangling structure noted in the anterior mitral leaflet, and also the thickened aortic wall with the RCC prolapse, and a mobile oscillating structure in the RVOT which moves with the cardiac cycle. So this is again the parasternal long axis view with the color Doppler across the interventricular septum, indicating perimembranous VSD with the gradient of 150 mmHg. Cup and saucer view. Here we can see multiple vegetation in the mobile vegetation attached to the pulmonary wall, which is extending into the pulmonary artery and RVOT, and also we can notice thickened RCC. This is the force chamber view. Here again we can see in the AML dangling structure is present, and also moderate mitral regurgitation, mild TR is present. Third one is the zoomed view of the tricuspid wall. Here also we can see a dangling structure which is on the septal tricuspid leaflet. So this is the follow-up echo. After treatment, we can see there is significant reduction in the vegetation size or complete resolution after treatment. So course of treatment, her routine labs revealed severe iron deficiency anemia. So PRBC transfusion was given. In vivo suspected infective endocarditis. Blood cultures taken as per protocol. Empirical antibiotic therapy started with injection ceftriaxone and ticoplanin. Her echocardiography findings showed a small restrictive perimembranous VSD with a gradient of 150 mmHg and vegetation involving the pulmonary, mitral and tricuspid wall, thickened aortic leaflet with the RCC prolapse, and moderate aortic regurgitation and mitral regurgitation. The blood culture confirmed granulocatena. So antibiotics continued. Repeat CBC was done. Further hemoglobin drop was seen. So additional PRBC transfusion was given. Later her hemoglobin level was improved. Serial RFTs showed gradual improvement. Clinically she was stable and planned for discharge with the injection ceftriaxone for 2 gram intravenously for every 12 hours for 2 weeks. 3 weeks post-discharge, she again presented with the shortness of breath. Vancomycin and gentamicin were started empirically and antibiotics continued for 8 weeks. Repeat echocardiography showed reduction in the vegetation size. CTVS consultation was taken and aortic wall replacement and VSD closure was advised to the patient, and surgical intervention was discussed with the patient. Yeah, multivalvular infective endocarditis is a severe and complex condition involving infection of the multiple heart walls. Granulocatena adiacin, it is a nutritionally variant streptococcus associated with high morbidity and mortality. Patient with CHD, previous heart surgeries, immunocompromised states and IV drug use are at a higher risk. They're present with the symptoms of fever, new murmur, signs of embolization. Complications like heart failure, systemic embolization and multi-organ failure will be present. Anemia is a common complication due to chronic inflammation, hemolysis, renal complications, which requires blood transfusion. Diagnosis is based on clinical features, blood culture and echocardiography. AH and EAC recommend penicillin G, ampicillin or ceftriaxone as a first-line antibiotic therapy combined with gentamicin.
Surgical intervention indicated in case of severe heart failure, uncontrolled infection, prevention of embolic stroke or valve dysfunction. So these are the differential diagnosis: thrombus or non-bacterial thrombotic endocarditis, Lambel excrescences, papillary fibroelastoma, caseous necrosis. So in summary, multivalvular infective endocarditis is rare but has a higher embolic risk and mortality. Granular cataladiacin is a challenging organism which requires prolonged antibiotic therapy, and serial echocardiography is essential to monitor the disease progression. Early multidisciplinary approach improves the outcome. These are the reference. Thank you.
Good presentation, Swati.
Raju R, working as Deputy Chief Cardiac Sonographer and Academic Manager in Narayana Health City. For the next few minutes, I am going to discuss about a rare combination of obstruction. And coming to our patient, a 50-year-old patient with exertional dyspnea, worsened with NYHA class 2 symptoms from last 6 months. There was a history of one episode of acute onset of chest pain 2 months ago. And currently, when he was presented to OPD, he was asymptomatic. And his past history was, he earlier 5 years ago diagnosed with hypertrophic obstructive cardiomyopathy, started on beta blocker, discontinued after a month. He was having a alcohol consumption for the past 20 years. There is no history of syncope, palpitation or other symptoms. No significant family history as well. Coming to his vital signs, he presented to OPD with pulse rate of 80 beats per minute. Respiratory rate was about 18 beats per minute, and he was febrile, and his oxygen saturation was around 96%, and BP, blood pressure at his upper limbs was 130 by 80 mmHg. And when it comes to CVS, he presented with loud S1, normal S2, and opening snap and mid diastolic murmur at apex and ejection systolic murmur as well. Coming to investigations, and he was diagnosed to have with ECG of normal sinus rhythm, left anterior hemiblock, and left ventricular hypertrophy. And coming to echocardiography, when baseline echo we found to have is coming to parasternal long axis, he was shown to have asymmetrical septal hypertrophy, which was maximum thickness at basal anteroseptum was around 29 mm, and respectively posterior wall thickness was about 14 mm. And there was, you can see some hugging ventricles at the parasternal long axis at mid-level. Coming to his color flow parasternal long axis, which was showing same impression that at mid-level he was having some turbulent flow and some mild MR, and aortic wall seems to be okay. Then coming to parasternal short axis view at different levels, which was shown mitral valve free from densely calcified lateral commissure, and medial commissure was free from calcium, and there was no commissural fusion. And we found to have his papillary muscles was hypertrophied and suspected in some accessory papillary muscle at this level. And coming to his apical windows, then with 2D findings, what he found to have densely calcified mitral valve along with some nature of doming of anterior mitral leaflet, significantly calcified posterior leaflet, and some calcium is extending up to caudal level as well. And we suspected he presented with a short chordae as well. And this chordae, initial diagnosis we made that this chordae is directly attached to the papillary muscle or another accessory papillary muscle. We was not sure about that. Coming to his apical fourth chamber with color flow, same impression. At mid-level, he got more turbulent flow across mid-level, and LVOT, there was not much turbulence. Coming to apical long axis with and without color flow, you can feel the same. These mitral wall densely calcified at margins, as well as a caudal attachment also you can see. And his gradients at mid-level, he was having almost moderate obstruction at mid-level. There was no LVOT obstruction, and his mitral inflow gradient around 18/10, which is showing significant mitral stenosis. And we were suspecting, we ruled out by echo, initial diagnosis, it was not the cause of rheumatic heart disease, but later on we sent this patient for multimodality imaging. Coming to echo findings, we given as HOCM, and significant mitral stenosis may be query direct attachment of papillary muscle to anterior mitral leaflet, or double query rheumatic heart disease. There were other normal LV function. And coming to multimodality imaging, his TE images shown, again same that 4-chamber view as well as short axis views, long axis views proved that this mitral wall has significantly calcified as well as doming in nature, and his aortic wall looks fine, and short axis you can make out that accessory papillary muscle as well. Coming to other multimodality imaging, MRI, we ruled out by MRI. MRI also proved that there was significant HOCM at mid-level, hypertrophic obstructive cardiomyopathy, and features of moderate to severe mitral stenosis. And what they ruled out was his AML length was around 26 mm in length. Mitral leaflets were thickened and restricted movement, hypertrophied papillary muscles, and prominent epicobasal bundle attachment. Coming to conclusion, HCM with mitral abnormalities. In patients with HCM, the rate of intrinsic abnormalities of mitral valve is less as observed in echocardiographic studies. These abnormalities were anomalous mitral papillary muscles or quad-A, direct papillary insertion into the mitral leaflet, direct restricted leaflet abnormality, elongated leaflets, caudal rupture, restrictive caudal abnormalities, mitral valve prolapse, myxomatous valve, and mitral annular calcification. This was the article we went through, and we found to have it is not rheumatic heart disease as well. This patient was referred to surgery, but unfortunately we lost this patient as he is migrant worker from NRI. He's NRI from Malaysia. He is migrant worker. He was refused to have surgery, and we lost the follow-up. What is the take-home message from this talk is, a thorough understanding of the anatomy of this combination is necessary for optimal management of such patient is needed. Multimodality imaging as transesophageal, transthoracic, and cardiac MRI, if required, plays a major role in the initial diagnosis. Thank you.